Well, I want to thank everybody for coming on a Friday afternoon for the CFIRE Prevention Corps' first in a series of discussions. I also really want to say that the CFIRE, fortunately, is new. Fortunately, we have it. But we really want it to be all of ours, and we want it to be something that meets everybody's needs. And really the goal of the CFIRE is to focus, promote junior faculty, postdocs, fellows, and integrate people's work and facilitate research, integrate biological and behavioral work. So we've made some guesses of what we think would be useful to everybody, but there are only guesses. We've done some needs assessment, but please, please let us know what will be useful in the future for you. We're putting together a toolkit for prevention toolkit for researchers and for grants making. We're having series like this. We'll have a consulting service that we're putting together as well. But the more feedback you can give us on how to construct the CFIRE, the better, so that it can really meet the needs of the Hopkins community and really facilitate researchers and students inside and outside of HIV working together more productively. Is anybody here not worked in HIV before? I'm just thinking for our esteemed presenters, just having that information may be helpful. So today we're fortunate to have Dr. Amy Knowlton and Craig Hendricks. Dr. Knowlton is an associate professor in the Department of Health, Behavior, and Society, and her work is, lo and behold, in adherence. Surprise to everyone. Working a lot with disadvantaged populations and social factors in adherence. And she also has a new project working with EMS to promote the access to appropriate care and treatment for drug users in the Baltimore City. And our other renowned speaker is Craig Hendricks, who's a professor in the Department of Medicine, and he's director of the drug development unit. He's into pharmacokinetics and pharmacodynamics. He's been integrally involved in HPTN and PI on several projects for looking at microbicide development and assessment. And so the way we'll work today is Amy will present behavioral approaches to adherence. Craig will present biologic, and we then will open it up to your questions, queries, and suggestions. And with that, I'll let Amy take it away.
I should be putting this. Do you have any idea? Here?
Yeah, that looks good.
And I'll clip this somewhere. So I wanted to first point out that we have a little bit of change on the title of the presentations, that we're not making a clean break between behavioral and biomedical, because after all, adherence is about behavior. So that dichotomy doesn't seem to really fit here. But what I'm going to mostly be talking about today is indirect approaches to medical adherence assessment, and some of the remaining challenges in the literature in how to assess adherence. So we're going to be very informal, at least I am, so if you have any questions, feel free to ask, to interrupt. First of all, I wanted to give a bit of an overview about defining terms, some of the methodologic considerations in optimally assessing adherence, and touch on issues of what the gold standard is, and then just highlight some, or touch upon some of the common approaches that have been used for assessing adherence. Can everyone see the slides okay? Is it going? Okay. So by medication adherence, or ART adherence, of course, we're talking about the extent to which patients, participants, people are taking medications as medically prescribed. And we know that ART adherence really involves a constellation of complex behaviors. And it often incorporates dimensions not only of the dose of medication, but also the timing or schedule of the regimen, as well as the instructions, for example, dietary directions. So assessing adherence is important and coming up with standard measures for a number of reasons. First of all, so we can target interventions directed at folks who are having challenges adhering. And then secondly, to be able to evaluate such interventions. And then thirdly, of course, so we can make comparisons across populations and studies. So I hazard to talk about validity in a room full of epidemiologists, but I just wanted to throw this out that, of course, when we're trying to establish optimal methods of measurement, we're interested in aspects of content validity, or the degree to which a measure incorporates various dimensions of what we're trying to measure, and that it has criterion validity. That is the degree to which it's associated with some kind of external criterion. And usually with ART adherence, we're looking at some kind of electronic device monitoring that Craig's going to touch on in his talk. And then lastly, does it have construct validity? Is it associated with other related variables, or theoretically, does it seem to be associated with other things we would expect it to be? And usually viral load is the measure that's used for comparison here. But of course, we know that viral load can be potentially confounded by a number of factors, including viral resistance, the potency of drugs taken, etc. So is there a gold standard measure? Well, of course, everyone, probably except people new to the field, know that there is no gold standard for assessing adherence. And in fact, there's no gold standard really for assessing adherence to any medication. And the field itself is surprisingly very, very, at a very early stage. That, for at least 15 some years, in HIV, we've been so focused on medication adherence. But, amazingly, we're really leading the field in many ways, many areas of medicine. So, thank you. And so all the measures that, are currently used, either in research context or clinic settings, they all have their limitations, in terms of cost, in terms of burden to the patient, participant, or staff, or in terms of the validity, cost, etc. And there's also very little understanding of how to adjust for the errors or biases that are inherent in each of these methods. And also some of them, I should point out, of course, introduce construct irrelevance error as well, variance that really isn't fully even acknowledged, let alone accounted for in our research. So, some self-report approaches. Now, I start with this because the most simple-minded of all, of course, but there's a lot of interest in this for many reasons, of course. Most of the research, though, most of the work in this area has really focused narrowly on dose adherence rate and how to assess that. And there's no real standard time period used. Various ones have been used. Some of the more commonly used self-report instruments are the adult ACTG measures, which look at dose adherence rate for each medication that's prescribed, and then visual analog scales. I couldn't find one that's more typically used, but usually they're mark-offs for each decile, and the measure can be converted into either a continuous score of adherence or a dichotomous measure. And again, there's no real standard on that cutoff. Usually it depends on the measure, depends on the degree at which there may be a ceiling effect, and ideally it's a correlation with viral load. For sure, the more potent medications out today don't require such a high level of adherence as they used to, the 95% cutoff, but yet we have so much ceiling effect problems that you often see 100% as being the cutoff score. So some of the disadvantages are, of course, very obvious. There's problems of recall bias, problems of social desirability tendencies, as well as lack of standardization and overestimation. The advantages of self-report measures just certainly outweigh some of those disadvantages. Feasible in either clinic or research settings, very low cost, and amazingly, there's a lot of evidence that they have at least moderate correlation with viral load. Now, some of the challenges that have been found have been addressed in various ways, including having introductory statements, either in the research context or the clinic context, of really talking to people about the challenges, acknowledging the challenges of adherence, and making it more socially acceptable for people to disclose non-adherence. And then also, of course, using ACASI, audio computer-assisted self-interview methods instead of face-to-face, or lastly, using some kind of a multiple measures. So, some folks have recommended that measures assess various different dimensions of adherence and that these be combined. Some studies suggest there's more external criterion association with such measures. But I want to point out too, though, that this is really where a lot of the movement and breakthroughs are happening right now. So I think we can't give up on these self-report measures. That just in the last couple years, there's really seems to be a lot of evidence coming out on the validity of some of these very simple, even single item measures. And so they really seem to be favored in a lot of clinic settings and some population level research over the multi-item measures. There seems to be growing consensus on a 30-day recall period, rather than the 3, 7. And then also, as we begin to, have, we find more and more evidence that a particular single item that incorporates the 30-day recall period and assesses overall ability or success in adhering to one's regimen. There's a couple studies now that have found that such a single item is very strongly associated with objective approaches to assessment of adherence. So this is really exciting. So not something to discount. You know, very simple-minded, not rocket science, but you know, it's exciting. And that some of that evidence has been found with highly experienced, treatment experienced folks, substance users, et cetera, where you, and also that it has much less problems with ceiling effects than some of the other single item measures. So pharmacy records. Now these have also been used, and this is usually done in a closed pharmacy system, say where everyone's using the same pharmacy or a single payer system. And the calculations are usually done by assessing the actual refill dates with the expected refill dates, and then assessing either or calculating the days covered or the treatment gaps, medication gaps. And some of the early work coming out of British Columbia has been based a lot on this pharmacy record data. So it's really, you know, it's wonderful to be able to look at population level adherence. And of course, it also avoids a lot of the challenges of self-report data, you know, recall errors, et cetera. And of course, this pretty good association with viral load. However, you know, there are lots of disadvantages as well, because it really, you know, you can't really distinguish between not having the medications and non-adherence versus treatment interruptions from other means, like if a physician, you know, switches regimens. And it also, you know, there's a problem if people have multiple sources of their medications and whatnot. It also, there's no standard method for operationalizing adherence with the records, at least at this point. And lastly, of course, it assumes that if you have the medications, if you've got the refill, then you're actually adhering and taking them. So very loaded assumption there. So again, usually more valuable in understanding population level adherence than individual level. Now, pill counts have also been used, both in the research and clinic setting, again. And most of this has been done in terms of asking patients, participants, to bring in their pill bottles or whatever they store their medications in, and then having someone count them and compare, you know, how many pills are expected there if someone's, you know, been adhering, looking at the refill dates, versus how much is expected to be there. So, you know, generally low cost compared to some other methods, but also has some disadvantages. You know, it's very time intensive. It's really not the most feasible in clinic settings for that reason. And there's also the challenge of pill dumping. You know, some people can just pour out their meds on the way to their appointment, you know, and it's really hard to distinguish that from actual adherence. And of course, establishing that refill date, you know, there's just lots of issues there as well. Often these measures seem to overestimate adherence as well. And it assumes that there's no other source or place that people are storing their medications. So one of the ways in which this has been addressed is to have unannounced pill counts. And this has been very successfully used either in terms of home visits or phone-based unannounced phone calls. So there you have to bring folks in, or at least somehow give them the resources, you know, the pill tray, whatnot, all the supplies they need, train them in how to count, assume they have enough, you know, skill and functioning to be able to do this, and then someone makes the call or shows up and asks them to count. So that's been done, you know, in settings both in the U.S. In Africa as well, very successfully. highly associated with viral load. Okay, and then I wanted to touch on medication taking diaries. And I think how we define the terms we use is kind of arbitrary. It's kind of a fine line with some of these electronic devices. But a lot of this kind of intensive follow-up with patients, has been, or diary taking, has been done by pen and paper in the past. And of course, high burden there of the patients, and not the most feasible. But now with electronic devices, this explosion of technology, there's so many more options here. So lots and lots of interest and work happening. And a number of you folks I know are involved in this area. So this is very exciting. With medication taking diaries, usually this is done not only to assess adherence, but also to gather lots of rich data about contextual factors that may be going on that influence adherence. So there may be, say, periodic prompts from the electronic device to the patient or participant, and say 4 times a day, within these certain time periods, there's the person's asked to self-administer a survey and respond to in terms of information about medication taking, other kind of emotional, social factors that were going on that may have affected their adherence. So lots of rich data on contextual factors here is possible. But again, this also, relatively speaking, is a high burden on patients. And there's also the issue of, the massive amount of data. We know that, in this era, it's much easier to collect this data than to figure out, how do you find the signal. So lots of work happening in this area, though, to figure that out. And again, though, much more usable in a research setting than a clinic setting, and usually on just a short period of time. There's only so long that people are going to be intensively, participating with such intense monitoring. But it's also encouraging, though, that there's little evidence of intrusiveness or reactivity. In fact, such an approach was used as an intervention to improve adherence in pediatric population. And they saw this as, a negative, that it didn't work because the nurse phone-in had no greater effect than, or less effect than using this device. But in a way, for monitoring, for assessment, that's a positive. So, okay, so generally, let me wrap up here. How these compare, usually electronic devices are thought to kind of underestimate adherence, and then self-reports tend to overestimate adherence. So often, there has been, I don't know about often, but there has been an effort to try to use composite scores, especially in larger population studies, or studies that are aggregating data from various different studies. Using, say, some kind of hierarchy of quality of data has been used to come up with composite scores. So, for example, if there's electronic data or missing data of electronic records, then adding pill counts, and then if there's no pill count data, then use self-reports. So that has also been shown to be highly associated with viral load and other criterion. And then as we have more population specific predictors identified for non-adherence, then it is possible perhaps to look at ways in which we can come up with a set of variables that may be predictive of non-adherence. But of course, that's more population than value than patient patient-level value. And then lastly, I just wanted to mention that as we do more couples-focused intervention, prevention, there's greater and greater interest in research coming out on potential use of proxy reports. And I really kind of think of directly observed therapy as falling within this as well. So DOT has been used extensively for TB control. It's a very time-limited therapy, need for adherence, but and certainly needs to be modified for assessing adherence on a ongoing basis for HIV. But lots of very innovative and encouraging results there, including from some folks here at Hopkins, Greg Lucas and Jean Chega. And also, there's recent evidence indicating that for some people, especially for highly vulnerable populations, that for whom self-reports aren't as valid, like seriously mentally ill, it's good to see evidence that in some studies, informal caregivers or main partner reports of patient adherence are more strongly associated with external criteria than patients' own self-reports. So that's encouraging. So that's all.
Mechanisms, biology.
Are we having questions and discussions afterwards?
Yeah,
Or-
I think that's
Here we have in the garage. Thanks. So I will talk about biomedical approaches. Most of this focus is going to be on using drug concentrations and pharmacokinetics to make some judgment about adherence. But I'm going to tie this all together midway or near the end to talk about electronic event monitoring, which I think is probably the best, and you've already heard important parts about that, but I think it's very useful in combination with what we're doing here. And what I'll try to put together is the path we've been on for the last, 4 or 5 years to try to develop this, because it hasn't been used so much and certainly had not been used in the prevention setting in pre-exposure prophylaxis, either oral pills or topical gels or rings or films or whatever. There's all kinds of stuff in the works now. So I'll sort of go through this, and if I can get this, oh good. So there's a couple of questions here, because I think if you have drug concentration, one of the values right off the bat is it's a twofer. If you can find a way, and I don't think we've yet found a way to use it very precisely for individual adherence assessment, but we're getting close. If you get that, you also have some indicator of how close that individual is to being in the right place in terms of their concentration. So in fact, if it doesn't tell you anything about adherence, it might tell you about if you're where you want to be. It might not tell you why you're not where you want to be, but it suggests there's a problem. And then the issue is it the way the body handles the drug, or is it the way the body doesn't take or does take the drug? And we'll sort of tease apart those two things, which is what the first was all about. So we're going to start at the population level, and we're going to look at studies. In fact, we're going to look across studies to see what I think is a clear concentration effect that determines different outcomes in different clinical trials for pre-exposure prophylaxis. We'll focus on oral studies. The issue is, what's the source of that? And I'll try to make the case that it may be a combination of individual pharmacokinetics, how the body handles the drug, but also adherence. And then we'll talk about making a judgment with that data about population-level adherence and teasing out individual pharmacokinetics. Maybe I don't have to stand in front of it like John Madden. Here we go. And how we can use that perhaps to inform the design of the study for the future going forward. But if possible, this is really where we're getting to the meat here. What I'd like to be able to do is to measure individual-level adherence, because in a clinical trial, it would be useful to understand the outcomes, the effects, which would be the last part here, if you understand adherence and you understand the kinetics. Because what you really want to do in the clinical trial is understand, if the trial worked, why did it work? Was adherence good? Were the concentrations high enough? And if it failed, were those one or the other not true? So both of these contribute a lot to that information. So this is a schematic, and there's a lot of boxes here. And you can tell I'm a physician perhaps because I put adherence, all the complexity is somewhere else. And I make it like, adherence is just one of these little boxes. But, Dr. Knowlton just deconstructed all the complexity of adherence as a much larger topic. I don't have those skills, so I'm just going to put in a little box here. But what I do want to show is the relationship here. So here you have a drug regimen, a number of pills, how often you have to take them. And for PrEP, thankfully, it looks like maybe once a day, maybe something different. Maybe we'll talk about that. And then the participant, the research participant, or a patient in that setting, in a clinical setting, either does or doesn't take it as ordered, as suggested, as recommended. And then the body does its pharmacokinetic thing. That is, the drug is cleared in a certain way. It goes into different parts, into different volumes in the body. This is sort of how fast the drug is absorbed. And these are all different for each individual and even for individuals over time. And then you end up with a drug concentration. And we're going to start at this point because this is what we're going to be measuring. And what we're going to try to see is if we can infer backward from a drug concentration to understand adherence patterns. But to do that, of course, we're going to have to understand this intermediate step of kinetics. To know how the individual was handling the drug, because there's going to be a lot of variation for some drugs more than others to do that. Now, the other value, as I said, the twofer, is with the drug is it also goes forward. So the drug then interacts in a complex way. Hopefully it doesn't cause too much toxicity. That's the toxicodynamic thing. But hopefully it interacts in a positive way to actually prevent HIV infection. And there's a whole bunch of these other variables sort of in the red passage here. The sexual behaviors, parallel to the adherence behaviors, the viral kinetics, similar to the pharmacokinetics of the drug, and then the viral dynamics, what it does interacting with cells and the immune system and so on. So hopefully here we can also, if we have drug concentration, use this to anticipate or explain outcomes on the other end in terms of seroconversion. So it's right in the middle of this. If we can find a way to look both backward and forward, either one would be great. So let's go ahead and move forward through that. So we'll start at the population level. So this is a number of, these are the topical microbicide studies that have been completed. These are the oral studies that have been completed. These three studies showed significant impact. The IPREX was in men that have sex with men. They took Truvada once a day, 42% relative risk reduction. This is the Partners PrEP study. Depending on whether they took Truvada, a fixed dose combination, or tenofovir alone, 75 or 67% relative risk reduction. Very good. It's not 100, but very good. And then CDC TDF2, this study was done in Botswana. Very similar here. These folks took Truvada, 63%. So these are strong, strong signals. If you look within these studies and say, can I measure drug in these individuals? Is there a difference in their outcome? And it turns out in this study and in these studies, that was clearly the case. You bump from, you see here, from 42% to 92% relative risk reduction. There's not as much of a bump here for these, but they're already fairly close to the top. So within the studies, there is a clear concentration response. I don't know if this is adherence. I don't know if it's pharmacokinetics. So we'll try to tease that apart. And this is just looking at relative risk reduction. So this would be no protection. This would be perfect prevention of HIV infection. And this is the FemPrep study. And then you've got IPREX and these partner studies. These were both done in heterosexual men and women, so it's quite a mixed population here. But here you have nothing happening. Here you've got sort of a middle in effect, and then pretty close to the top, but not quite up there. There's still some room to go. And I'm sorry, and this is looking at concentration. The issue is this difference in concentration between this study that failed to show a difference, it's a successful study, I'm trying to get that right, and these studies which showed a statistically significant difference in prevention, is it because of adherence or pharmacokinetics? I'm going to come back to that. I have to do something in between. So one thing you could do with this pharmacokinetic data is establish adherence benchmarks, gold standards. just as Dr. Knowlton was talking about what is the gold standard and how do different methods work in that way. So there's two studies. This is a strand study was done on the West Coast. HPTN-066 was done on the East Coast. And both of these, what they do is they sort of simulate daily dosing, twice weekly dosing, or 4 times weekly, twice weekly, or weekly dosing. So it's simulating anywhere from 17 to 100% adherence. But it's simulating them in a very regular fashion. It doesn't take into account irregularities of adherence. So that's one limitation already. But you can use these to say if one takes the drug once or twice or 4 or 7 times a week, what does their concentration look like? Because we didn't know that before these were done, because all the studies that were done with the same drugs in treatment never made these assessments. So we've done this now, in fact, after the fact of the large randomized clinical trials, but at least we have this as an explanatory variable after the fact. So if we look at that, well, this is combining 2 bits of data. This is both pharmacokinetic data from IPREX. This is the study with daily Truvada in MSM, many countries internationally, and pharmacodynamic data. So first I'm going to look at pharmacodynamics. This is the same thing. This is HIV incidence per 100. So this is the risk reduction. No protection, perfect protection. And this is the geometric mean. This is the 95% confidence interval. And what you see is that once your concentration, and this is the active drug, tenofovir diphosphate, in peripheral blood mononuclear cells, because they're pretty easy to get to. Once your concentration gets above 16 femtomole per million cells, above this point, you're sort of in the 90–95% or better range of protection. So this is suggesting a target concentration that you would like to achieve with this regimen. If you have a concentration less than that, you see at some point you look just like the placebo group here. Now, if I superimpose on this concentration scale the strand study that said if you take the drug twice a week, this is your concentration. If you take the drug 4 times a week, this is your concentration, and so on for 7 times a week, daily dosing. Strand suggests if you take the drug 4 times a week or more, you're in good shape because you're up in that 90+%. If you take it only 2 times a week, you might be in trouble, although there's still some level of protection, it looks like. But I want to make the point that this may be a very different thing than prescribing daily and seeing what happens versus prescribing 4 times a week and seeing what happens, because then you superimpose the adherence on that prescription of 4 times a week. And you might get 4, you might get 2, you might get 1. And so you see, you have to be careful how you use those benchmarks. Right? But I think we're making progress to identify target concentrations. So now we know at what concentration we need to worry about losing our protective effect. And this is just another, this is the other study, HPTN-066, where we actually could measure these. This is the mean, this is the lower 95% confidence interval in terms of concentrations associated with daily, 4 times a week, 3 times a week, and on down to weekly. And we can sort of bracket these large studies. Partners PrEP and CDC, they look like they took it daily. So that's an indirect measure of adherence in those studies, assuming the pharmacokinetic variation is sort of, on average and not, there was no failure in the randomization there. IPREX, they look like they took it maybe 3 times a week, and that's not inconsistent with what the previous data was showing you. So this data has been generated but not analyzed to see what the problem was in voice. This was a oral study and a gel study, so we'll have to see if this fits into the same pattern. So far, these have all been very consistent. So we're, yes?
So FemPrep is the outlier.
FemPrep is clearly the outlier.
Worst adherence.
Yes. So that's, they didn't publish the median. In fact, the median for IPREX was in that, using their method, at the level of detection. Half were above, half were below. In IPREX, I'm guessing it was around 5. You can't tell because it might be around the quartile. I mean, the limit of quantitation was the upper 75% quartile, the third quartile. So it's clearly the outlier there. The issue is voice in the same place? Is the oral, which was another study, very similar demographics, similar entry criteria. Where's that going to fall? We don't know, but we'll know that. That'll be hopefully at CROI in March. Yes?
So does this assume once you get like a steady state level then? Or does it make a difference when you're taking the blood to get the
Sure.
concentration.
Okay, so that may not be my next slide, but we'll get there. So the studies, when you make this assessment is very important. And whether you use the level of the parent drug in the blood is one issue versus using these cells, because they take longer to get to steady state. If you were going to cut hair and measure drug in the hair, that steady state is even later still because it has a much longer half-life. So you have to take into account the steady state. But the fact is, sort of steady state is, we're talking about adherence. So the steady state is sort of a theoretical time when your fluctuations are sort of fixed fluctuations.
Isn't that
But
what this is assuming then?
so the data in this study, in these benchmark studies, does assume that it's steady state, and that's another critical piece because it doesn't, there are different kinds of 90% adherence, for example, and I'll go over an example of that. So it doesn't capture the pattern. It says if you are regular in your degree of poor adherence, this is what your concentration looks like. So you might come to the clinic after a good week, and or you might do that intentionally. You might pop a single pill on the way into the clinic, and you can completely fool the system. And I'll show you an example of that here. So a great point. So here we can generate this. This is a median. There's a 95% and 99% confidence bounds. This is with oral dosing. This is with vaginal dosing. And this is a study, and I'll use this study for a lot of the rest of the data. This is a study in 144 women in the US and Africa. It was done in Africa, it was done at many of the voice trial sites. And so here's something, but I'm going to use this as the cutoff. In fact, I'm going to use not the concentration at any time, not at the peak. I'm going to use the trough concentration, the 24 hours after a dose. The lower 99% confidence interval is around 40 nanograms per mil. So I'm going to use that and say, okay, now if I look at all the data from the study, and I'm going to put them on the time axis wherever they told me they took their last dose. So they come into the clinic, we draw their blood and say, when was your last dose? And they give us their time. And they all said between 12 and 14 hours because they were told to take it at night, and most of the clinic visits are in the morning. So this is what it looks like. This is the oral dosing arm. This is the vaginal dosing arm. There's not a lot of points that are above the lower 99% confidence bound, even if you use the 24-hour 99% confidence bound, which is late. I mean, that's the most conservative measure you could use. And this is, depending on where you measure this, it's either, it's about a third or two-thirds, roughly, that we're not taking it in a way that was prescribed. The problem with this is that some of these folks may fall off of this because their kinetics are different. So let's tease that apart. We'll come back to this adherence versus PK again. Now this is an example of when we asked the subjects when they took their drug, or we asked them the single question about in the last week, what % of your doses did you take, or in the last month? In fact, I think it was the last week was the frame of reference. So I've already learned today, not the best way to ask that question. Okay. So hopefully I'm a little teachable. So this is the % adherence. Now I bracketed this at 40 just to point that out. So we're looking at 40 to 100. This is self-report adherence. This is that lower 99% confidence interval. And you can see how, where these folks down here that said, they didn't take it all the time are in fact below here. So this clearly is working. And you will see a concordance. If you were to look at the MEMS caps, you saw the inter-method correlations, and they exist. The issues are how accurate they are at predicting a % adherence. But these can be useful in some of these folks that say, and I think the lesson here is that those folks that say they're not taking it are probably not taking it. Those folks that say they are taking it all the time may also not be taking it all the time. There's a fair number of those. So this is just from this, and this is from a fairly rich set of data. So again, around a third we're below the 99% bound. Okay, but let's try to get this to an individual level. Individual kinetics and individual adherence, if possible. So the way this would work, when I started out, I thought maybe we could get to this point. And I mentioned this before, the drug concentration as an adherence measure is quantitative. It might be quantitative. I'd like to get it there. I don't think it is there yet. But the other is, as I said, it's a twofer. It may get you to quantitative assessment of adherence, but it tells you what the concentration is. And if you know what your target is relative to some level of effectiveness, that can be doubly helpful. In fact, it's really what you want. whatever adherence is, if it gets you to your target, it's good enough. If it doesn't get you to target, whether it's because of kinetics or adherence, it's not good enough, and it needs an intervention, changing dose, changing adherence. So very simply, and this was described previously, the same sort of thing. You have an expected value in relationship to an observed value, adherence concentration. So we have expected values based on populations, based on directly observed dosing, and we have an observation in an individual. I'm going to turn this into a percent, and that gives me my answer, percent adherence. But you all see that, these Greek letters, they drive you nuts, right? I mean, that's where the devil lives, in the Greeks. I don't want to unpack that one, but anyway, I didn't come out the way I want. But so you get this variability is what kills this whole thing. I mean, that's the problem. So to make this work, you have to understand this relationship. Now, it doesn't have to be dose proportional. By this I mean if you double the dose, if you take 2 doses a week, you have twice the concentration that you have with 1 a week. It doesn't have to be proportional like that, but you have to understand the proportionality. Otherwise, you don't know how to interpret this data. So we need to do studies for that. In fact, that's why we did this. That's why the STRAND study was done. That's why 066 was done. And then you have to understand, where'd it go? There, the variability, the intra-individual and inter-individual variabilities. So we can get at a lot of this through pharmacokinetic modeling. You collect, in fact, the way this works, you can collect 1, but hopefully 2 samples at least, but 2 samples of blood after an observed dose. So you know when the dose was taken, and then you see how that individual person handles the drug. And then you can look at the 144, as we did in this study, look at 144 women, and generate the typical population PK terms for clearance and volume distribution and half-life, that stuff. But then in addition, because you've got all the other individual data, you can see how their creatinine clearance changes that individual's estimate for what their expectation is for how they handle the drug, or how their age, or how other drugs or other genetic factors might affect other environmental factors as well, which we'll get to in a moment, might affect how they handle it. So this gives you a lot of increased precision in your estimates. So now we're getting closer to the individual level. Only takes 1. You can do this with just 1. We've done this. We're doing this now in Partners Prep, and we actually have pretty good estimates. But it works better if you have a couple of observations, and we'll look at some of that. So even with this, if you have a population PK estimate, which is what I've been showing you, it may be very useful to target adherence interventions based on individual predictions that's much more finely tuned than what I've already showed you. So let's just take one example, because there's different ways you could do this. Let's say our intervention threshold is if the individual's predicted concentration is below 20% below what we expect it to be. You could also say if it's high enough, you don't need to do anything, but let's say we're just trying to measure adherence. Then look at who falls into that bin. Based on sites in the study, the A sites, half of them were below that. So half of them were 20% below where they were expected to be based on their individual kinetics. So that's adherence. We've controlled for kinetics. That's adherence. And at the B sites, this is not entirely, but this is largely African sites, and this is largely US sites. It was only 13%. Now, there's a lot of reasons that could be. It might be because the US sites, they know they're going to be checking their blood levels, and they're taking a pill on the way into the clinic. It could be that simple. But the kinetics are controlled for in this analysis. Same thing. So, but let me show you how those models are based on data that's polluted, confounded by adherence. So if I have the A sites, these are B sites, and the A sites, they come into the clinic, I draw their blood before they take a dose, and then I measure their blood after they take a dose. Well, what you see here are 2 things. They have the same decay of their drug over time in both sites, even though there's a 5-fold difference in their initial concentration. And to reinforce that, I'm going to subtract the difference. I'm going to control for this, and these are completely superimposable, at least the medians are. So the pharmacokinetics, what happens to the drug after it's taken, is identical in both populations. What's different is their pre-dose concentration, and this is determined by when the last dose was and the dose before that. So you see, now we're getting to be able to tease these 2 apart, and I think this is clear evidence. I still don't have individual estimates of adherence, but it's clear to me that most of this difference that we're seeing, and this is true I think in those large studies, is adherence. It's not individual kinetics. So I can build, and I won't go into this model, but basically we can put a term in the model that says, let's use that pre-dose concentration. We're going to use this concentration here, or that one, and we're going to build that into the model because what this is a function of what came before, and if we're measuring this concentration and a concentration after, we'll learn a lot more. And in fact, then if I look at different categories, I can see statistically significant differences in this population model for the adherence measure, but the clearance, the pharmacokinetic term, is the same. This is a more formal way to do what I showed you in a very simple concentration time plot. Okay, so this was described before. There's sort of two competing technologies here, and this was just such a great picture and logo. MEMS CAP, a small world with no limits. The corporate world just thinks differently, don't they? So this is this micro-electromechanical, that's the MEM in MEMS CAP. And they use these in lots of different applications, but the one we're talking about is to put this chip inside the cap on a pill bottle. And this one actually has a readout for, I think, how many hours since your last dose or until your whatever. There's some kind of a memory aid here built into this. It's a bit large, though. This is clunky. It's not the sort of thing. And the problem is, was pointed out before. You've got one of these things, and you could, if you're tired of taking pills, you can just sort of open it on schedule and not take a pill. Or you can show your friends what a cool device you've got, and then you have false positive events. But more often than not, as was described in Dr. Knowlton's talk, you get a over-representation, an overcount of actually doses taken. So, and there's another technology which I love. We're actually building this into a study that we hope we'll be doing in the next year. This WISE pill, where you open the device. This is a little pill container here, which is also clunky. This doesn't seem to be so portable. But you open the device, and when the device is opened, it sends a wireless signal that records. Where's the device? So here's the device. So this sends a device to the server, which then notifies the researchers that the dose was taken. If the dose was not taken within a predetermined time interval, which is up to the researcher, it then sends a text message to the individual, which you can make it discrete so it's not clear what's going on here. But at least the individual will understand what it is. And we're actually planning to use this so that we will roll someone over from unobserved dosing to observed dosing if they fail within a short period of time, because we want to be sure they're taking absolutely all their doses, but we don't want to do this for everyone because that makes it very expensive. And we probably would cut down on recruitment issues because not everyone's going to want to come into the clinic every day for 7 weeks, which is required in this study. Okay? So these are the electronic, and this is the point I was trying to make before. This is the huge advantage of these. And I would consider these so far the gold standard, at least in terms of these events. They do overcount, but just look at this. These are 4 examples of 90% adherence. This is from work that Terry Blaschke did, which has been some of the best work in the HIV-related adherence field. Terry's a clinical pharmacologist. This is a patient who delayed initiation. This is where they missed 10%, mostly here, a few doses here and there. These blue dots are the events, the pill-taking events. These bars, vertical bars, are missed doses. This subject took almost all their doses until the end, and then they stopped earlier than they were supposed to. Here's a subject that had a holiday right in the middle. And this individual was sort of that's pretty random. I mean, it starts off strong, and then you have these random dropouts. What I want to point out here is that with either HIV treatment or prevention, this is a very different 90% adherence than this. If you stop taking your antiretrovirals and you've got virus on board, it will, it's regrowing in probably the first day, but you can't measure it. But after a week, easily you'll be able to measure that. Or you'll have resistance that's occurring because you've got some drugs waning and virus being exposed to that to select for resistant variants. This 10% is very expensive, and same likewise for prevention. If your concentrations are low, and the holiday was because it really is a holiday, okay? You read between the quotes. That may be a bad time not to be taking your drugs. And so over here, these events may not be very important. If you have a drug, and tenofovir is the drug been studied, tenofovir, the active form, has a half-life that's Well, if it's days. It's maybe 4 or 5 days. It can be very long. It has complicated kinetics, so I won't get into that. But these are probably meaningless. That 16%, or excuse me, that 16 femtomole per million cell cutoff I talked about from IPREX, you wouldn't get anywhere near it with this kind of adherence. And that's still 90% adherence. So 90% can be perfectly fine. It depends on the setting. It depends what drugs you're taking and what you're trying to do treatment-wise or prevention-wise. Okay, so how would you measure this? And there's some of the issues I mentioned before to the question. This is that 066 study. This is the simulation for the study, not the actual data. This is the simulation for taking it regularly, once a week, twice a week, 2 pills twice a week, and every day. And what you see, this is measuring inside peripheral blood mononuclear cells the active form of the drug, tenofovir diphosphate. It has a half-life about 150 hours. At least that's what it's published to have in infected patients. It's not at all like that in healthy volunteers. It's very easy to discriminate daily dosing from even double dose twice a week, equivalent of 4 times a week dosing. And it's no problem to differentiate daily from weekly, right? That should be easy. Now, I've cheated because I haven't shown you the variability. But at least if there were no individual variability, it'd be very easy. So imagine at any point here, if you sampled at any one of these points, you could, even early on, before they were at steady, you see right here it's hard to differentiate. So the time to steady state is important. And it takes this one longer to get up to steady state, but it's differentiable early on as well. Imagine drawing a line through any one of these events, and it's very hard to differentiate daily from 4 times a week. In fact, some of these you can't differentiate daily dosing from weekly dosing, depending on the day you sample. So choosing a drug that has a longer half-life gives you different information. It's not necessarily better, though. It all depends on what you want to measure. And so here's what's happening. This is looking at, I guess there's like a couple weeks of dosing here. These are individual doses. So this is the concentration in blue that results for the parent drug that has a short half-life of only 17 hours. The red is the longer half-life of the active drug inside white cells, inside lymphocytes, CD4 and CD4 cells. So these are actually all cumulative. So these are going to stack up. And that's what I showed you in the last one. But if we take a little slice just right here and explode it here, what you see is that when you take a sample, your sample for, if you're measuring the plasma concentration, not inside a cell, is influenced only by 1, 2, 3, 4 doses. So you can only tell what's going on in the last 4 days. And if you're measuring this long half-life inside cells, you've got, I don't know how many there are there, but there's a lot more doses that are influencing what you're measuring. So it has a greater look-back capacity. It tells you back in past better. And if you were using hair, it would go even further back than that. The problem is that this is very insensitive to a holiday even in the prior 3 days. This is not going to miss a holiday in the, this one is not going to miss it. So it depends what you're trying to look at. And this is that white coat effect I mentioned. Here's measuring drug in the plasma, short half-life, measuring drug in the cells, active drug, long half-life. We measured their drug as soon as they hit the clinic. This individual had nothing on board. To be able to make this point, I had to give him a value of 1. No drug. 1 hour after the dose, looks like everybody else. And they all look like they've been taking their drug. But if you look at the long half-life drug, remember, this is influenced by all the prior doses. There's nothing on board. And with 1 dose, you can't look like you've been taking all your doses. So longer half-life gives you longer look back, and you can sort of weed out some of the white coat effect. As it turns out in the studies, this is a very small number that actually did this. I mean, it's 1 out of 18. So not such a common event, at least in this clinical setting. So this is where I want to sort of tie it all together and finish. This is looking at different matrices to measure, measuring in the blood, measuring inside cells, or measuring in hair. And this was a study done by Al Liu and colleagues at UCSF, and you've already seen a bunch of his data from the previous talk. So this is taking changes in these to see how they correlate with these other measures. And as we mentioned before, the pill count, the correlations with pill count are not bad. They're statistically significant for all these measures. The MEMS caps are similar, but look here, this is 30-day MEMS cap. The hair doesn't work, or I shouldn't say it doesn't work, it doesn't correlate, because the hair is looking back over a longer period of time. It's insensitive to holidays or intermittent missed doses, depending on those patterns. over weeks, but it's a pretty good representative for months. But it all depends on what you want to know. So they don't correlate. And then here, this is self-report, and this is not a surprise. You heard this in the prior talk, and I've shown you this in our own study. And then the other issue with hair, I'm not trying to hammer a hair, but hair is complicated. If you've got red hair or blonde hair, God bless you. But we have to adjust for that in the analysis. And if you do any treatment to your hair, you know, Grecian or whatever, I actually have my gray, that also changes. So it gets complicated. Was that Dr. Farzad laughing there? Okay, at least he's got a lot more hair than I do. All right, that's why he was, all right. All right. Ah, that's the secret. All right. So tie this all together to finish. I want to show you what you can do if you put both of these together. And this is the value. So this is that same MEMS data. This is prescribed in red. This is as taken in blue with the holidays in the vertical amber bands. If you know what the individual kinetics are, and you can do this with 2 blood samples to get a fair estimate of what the concentration time curve will look like after a dose is taken, if you know when the events were and what the concentration, how it changes after that event, after that pill is taken, you can, after the fact, simulate the entire drug exposure during the period that you had these MEMS caps in place. So what this is here in blue, the red is what you wanted to see, the blue is what you got. And what this shows you is these downward excursions. You see some of these with a bunch of missed events. You see now you're losing all this concentration. And what this allows you to do is look at, to see at the end of the study, were these events, as they occurred in individuals, were these predictive of seroconversion failures? Were these, the number of these events predictive of seroconversion failure? So you're getting at pharmacodynamic data, seroconversion predicting data for the next study, but it also allows you to pick that target to say, in a clinic situation, how would you use this information? How many doses could you miss? What kind of concentration is your target, whether it's because of kinetics or because of adherence? I mean, they're both part of the equation. So the limitations, to summarize, the biggest problem in studies is that we're measuring drug levels. If you're on placebo, I can't measure your adherence. And it would be important to know at least that the adherence was the same in both. And there may be other behaviors that track along with adherence, which is a complicated discussion. I think the population-based estimates do work, and they're superior to individual estimates so far, but there's more work to be done, and I think we're going to get closer to actually making this work. These are discrete sampling times, are not continuous, and that's where these electronic event monitoring systems have a huge advantage, because they're not very expensive, especially if you buy them and then reuse them. I mean, because you can reuse the pill containers. They're like $150, $200 for those devices, but you can you repeatedly use them if you get them back. Some people like to keep showing their friends, I guess. So this discrete sampling is a limitation. But the other, in terms of logistically simple things like hair or dried blood spots, they only provide an average over very long periods of time. And that may not be what you're trying to capture. If you want average adherence, they're probably very good at that. But if you want to know about those holidays that we saw in this example, they're not going to provide that kind of information. So I'll go ahead and stop at that point, turn it back to Carl.
Questions?
Excuse me. I was just curious, so you presented the different methods that we've used for adherence in terms of ART, and I'm just going to go, but for the different studies that have looked at factors either related to non-adherence or factors related to improved adherence, did they change based on the methods used? I mean, do you see a difference, or are the factors that we've studied today, the behavioral factors, socio-behavioral or demographic factors, effect so large that it doesn't make a difference which measurement you're using to capture adherence? I think there's a difference between looking at predictors of adherence versus adherence and the outcome. And so I'm asking about predictors of the adherence.
Yeah, I think these would be very, there's enough evidence that, they have varying degrees of sensitivity to, that there's different patterns of association depending on the validity of each of these measures.
So like, do you know an example where
there's variation
one
in the
did
populations
better?
as well. Some populations are more compliant overall than other populations, so you may get very different patterns of associations that, really don't have so much to do with the actual behavior, of adherence, but the sensitivity of the measures, within.
Yes, but I'm talking about within the same population. So if you have the East Baltimore population, for example, and you're looking at, for example, how can we improve adherence? But you're trying to first get, so what factors are contraindicated or not allowing us to look at it? What are people who are persistent non-adherents or low adherents? Do you have, is there any data that says, well, if you use this, you're not going to see this, but if you use this, you'll see this?
That's a really good question. There have been a number of studies. Off the top of my head, I can't point to
Because
specific
the literature I've read
ones.
that it's nothing is standing out as I've looked at, at least the earlier literature in HIV, nothing stood out as when people just said you have to use a combination, but nothing, there was no differences in terms of predictors of. Like a lot of them are showing the same predictors of non-adherence, regardless of which measure of adherence they're using.
I guess that's altogether true in terms of some of the self-report measures. I mean, we've seen such wide variability in results that and in terms of the cutoffs used, we want to have it very clean often, and our measures, and so how you dichotomize adherent versus non-adherent, can give you very, very different results in terms of what associations you find. When the East Baltimore population, we have, the issue of so much substance use, so some of these, you can find that, some behaviors that are so highly prevalent, there's, it's a matter of statistical issues, ceiling effects, so you don't see the correlation, but, it's more an issue of the prevalence and, the particular cutoff that's been used. So, I would say that it's really, very complex in terms of what measures have been used over time. And certainly when you look at the data, from a decade ago, you're seeing very different patterns, where now you're seeing much more consistent associations, clearer patterns with measures as there evolves, greater consensus on how to measure this.
It's getting easier to measure too, because now we have going into more of the one pill versus multiple pills.
Oh, exactly, and that's
It's
wonderful.
much easier to measure here.
Yeah, and it's easier for the patients to actually adhere. So, much less instruction.
I have a question for my friend Craig. The adherence concentration, is it similar to inhibitory concentration? And if it is it variable in blood versus vaginal delivery?
Yeah, so that's a good question. The question is if I guess what you're saying is the target concentration that's identified, is it consistent in the clinical studies with in vitro data? Is that what you're asking? And the answer is it will. I'm not sure how comparable the data even are to make the judgment about that. But if you were to measure the effective concentration in plasma, you're measuring something that's not at all, well, it's related in an indirect way to the concentration of the active, so that'll be different than measuring it in the cells. So you'll get a lot of variation across those. And those, of course, are measuring drug in a distant site in the blood. I say this related to sexual transmission because they may not be related in a systematic way to the concentration in vaginal tissue, for example, if we talk about prevention in women, or rectal tissue in men and women with receptive anal intercourse. So they're indirect in that sense, and that's one source of a lot of the noise. It may also be true that tissue concentrations are irrelevant, and that's where having tissue concentrations that either do or don't correlate with outcomes to compare to how the blood concentrations compare is very useful, because I think that you can infer something about location of action in addition to adequate concentrations. So these things are all interrelated. The site where you measure it is very important. I don't think that you could have predicted that 16 femtomole per million cells was the target concentration, but I will say that if it is true that 16 femtomole per million cells is the target concentration for IPREX, it is a very different concentration, probably, than is required in a population of women who only practice vaginal intercourse, because the concentrations in colon tissue and vaginal tissue appear to be very different. How much drug gets there, how long it stays there is different. So you have to be very specific anatomically where you're measuring things if you're trying to measure effectiveness. If you're trying to measure adherence, I don't think it matters so much. There, maybe the closer to the pill going in is the place to measure. I mean, if you could put a video camera, we could miniaturize his device and put it in the posterior pharynx. That's what you want to capture the event, because after that it gets noisy. That's really what you want to know.
Great. Just following along on that, in terms of the gender issues, I think we've all been struck that oral Truvada or Knowlton looks consistently better in men than in women. And FemPrep really, in some ways, drags that out as an outlier. Your analysis, if I understood it, suggests that that difference is as much or more adherence related than it is biological gender.
So FemPrep is, so nobody took their drug in FemPrep. That's not true. Very few women took their drug as prescribed in FemPrep.
Yeah.
Their bodies are different, but they're not that different. Male-female differences are negligible. If you adjust for size, there are not differences. We've looked at that in partners and a bunch of studies. So that's just not true. But in the men, the concentrations on average in IPREX were half of what, I'm sorry, it wasn't a half. They were a fifth of what they were in partners and the CDC studies. A fifth on average. But when they took the drug, and their outcomes were lower, right? But when they took the drug, they were in the same range. In the same range of those that took the drug in those other studies, because the others weren't perfect. So they both got the bump, but the MSM study, IPREX, got a larger bump. The reason that if the women in the CDC and the partner study took the drug as seldom as the IPREX men took their drug and had 5 times lower concentrations, then they would look not very different than FemPrep, and I think they would have had outcomes like FemPrep. I can't prove that, but I think voice is in a position, if they're just a little bit better than FemPrep, they'll be on, well, in fact, our sensitivity we don't have to be much better, but it'd be nice if it's better and it still failed, to show that there is something different about receptive anal intercourse and how much you need to protect versus a preponderance of receptive vaginal intercourse and the need to protect. Because again, you've got to remember that women have at least two ways for sexual transmission. Men don't have as many, but at least women always are +1. Put it that way. Women are +1. I'm not totally fumbling these gender things, am I?
No. I'm bad for Friday afternoon. Greg.
So, nice talks, both of you. I was wondering about this reemergence of riboflavin and these biotracers that people have suggested. I think you mentioned your placebo thing. Is there something biologically inactive that could be added into a wide array of antiretrovirals that could be easily measured?
There are these tagans, and some of these are the ones that I know more about. So riboflavin is easy because the problem with riboflavin is it can be confounded because it exists naturally in food, and that's a source of variation. If you use a volatile, a butyl, something that will it turns into a gas as it passes through the lungs, and then you can breathe it out. So these devices, and they're very simple to sample. So you have a device, and you go home, you get your prescription. Placebo can be labeled, which is the real advantage. So you can measure adherence in placebo, you can measure the adherence in active, well, no one has to know which is which. You take your pills, and then at some interval, you're supposed to breathe into this device. And the device can send a wireless signal to say, they had drug on board, they didn't have drug. The device actually has a GC mass spec in it. I don't know how they do this, but there's a GC mass spec in this thing, and it says this is the profile. It's not so quantitative, but you're just looking for the signal. So those can tell you that. The issue, so that adds some expense. It does give you additional data, but what I don't know is you have to use the device, which is a behavior. So I don't know how to get around it. So those things can be useful. The big advantage is you can measure adherence in the ways that I was talking about in all the SIBO folks. But other than that, I don't know what the advantages are. I think there's significant behavioral, it's a behavioral intervention to put this device in the room, and then it's biased because you're asking people to pick it up and use it. Now maybe if they don't do that, that tells you something useful. That's possible. But so I think there are some limitations to that too. That's a much newer science, I have to say.
And how about, I quote some paper in a few of my grants or papers about how poor clinicians are at predicting who's going to be adherent or not. And there's an old paper that says it's a 50-50 coin flip. Is there any newer data with newer regimens, or has anyone really been able to assess what's the clinician's ability to predict who's going to be adherent and who's not? Do you know of anything that has looked
No,
at that?
I think I know what you're talking about, and this was HIV related,
Yeah.
where it was that, you know, physicians would make some assumptions based on, you know, social demographics or something, and, you know, injection drug users can be very good taking pills. And you know, folks that, you know, that do not inject drugs and, you know, maybe look different might not be terrible taking pills for very complex reasons. So I haven't seen anything to change that. We've done some looks, but this goes back to your question before about what are the characteristics of those that don't take pills so often. And we have seen that there are some socio-demographic things that we predict. The problem is that they're confounded by much larger variables like US versus Africa. And and that's different. And I think high school education and college in the U.S. is different than high school. I mean, there's just so many other things that are layered in there. It's very difficult to make judgments. So I don't know any good data. I don't think physicians are not great at predicting lots of things.
And the difference of adherence was that the adherence was actually perfectly matched with hypertension and other diseases before HIV came along. So it's in the study that they gave way back. So it really has not changed over a period of time. But the whole issue of there being substance abuse has kind of been debunked to some extent, because it's really about chaotic lifestyle or not. And somebody who is injecting urine regularly and is injecting it so they maintain and don't go into withdrawal and has some, you know, some routine to their life can do as well as somebody else. There's been studies that show that if you actually, if you look at chaotics and chaotic factors that people look at chaotic scales, that that's more predictive than whether somebody is injecting or not. You obviously don't know from your study.
And there is also literature showing that physicians are worse at predicting adherence in HIV-infected patients than nurses. So there is a lot of
So I just had a couple comments. I wondered if either of you had heard of, I heard someone mention that there are pills that rather than MEMS cap to get around, did the person actually swallow their pill or did they open the cap and toss it, that there are pills that when swallowed emit some sort of a signal to something that can be worn on someone's skin. And then, you know, it doesn't get absorbed and it gets washed out, but it can, you know, be put into pills to give you really...
It really is work being done in this area. It's all at the developmental stage, but I thought actually Craig was going there, and when this earlier mentioned something like this. There is a device that I saw demonstrated about a year ago in Bethesda, where you wear some kind of a device that I guess takes a picture or somehow, you know, can detects a signal that the pill actually transmits.
It's capsule endoscopy.
Pardon?
You take a capsule and it goes through your GI tract and takes pictures.
But it's a device that you wear around your neck
But-
that actually
but
detects it going down.
What they're referring to is nanochips that they put in the
Oh,
pill,
I see.
which takes a signal from somewhere in the body and they can put it under the skin that takes that signal.
So I saw a couple of months ago, there was an article saying the FDA had approved something like that, like a capsule that somehow, tracks it. So it's now, what I heard was FDA approved.
One of the problems, though, the challenges here, is Craig brought up, that, a lot of these methods or approaches to assessing the behavior of adherence require a level of adherence to the assessment instrument. And so you've already got half the battle, And like the MIMS caps, it's because these things are big and bulky. People don't use them normally to, store their pills, and they're clunky. They don't, take them out with them when they travel outside of the home. So, is it really, ideally you want some kind of measurement that, assesses behavior in real life context, assesses the actual behavior in real life. So, and none of these measures really meet that standard. So, still a lot of
Last question.
I think the whole idea of getting a blood sample and telling, and being able to relatively at least tell individuals, assess what the adherence is fascinating and very intriguing. I have two questions though, and that is, after you put in those other covariates, what's your R-square for the adherence versus, for your model in terms of predictors of your concentration? And then the second one was, so how much are we talking about in terms of cost? Like, is this a feasible way of thinking about it?
So if you did, I can't give you an R-square. And what I was trying to say too is that this is, I'm not sure how exactly this would all be done, but I think we're putting the pieces together where if, let's say you're somewhere in the course, you have a patient that's in a clinical setting, you have a patient that's been on the drug, on PrEP or on ARD for a month. And they're in the clinic and you draw 2 samples of blood. You might draw them a couple hours apart. That's already complicated. Let's say it's no more complicated than draw 1 sample of blood at 2 different time points during a long clinic visit. Okay? Along with all the other safety stuff you're going to do if they're on PrEP or on ARD. With that data, you can predict with a fairly good R-square, I can't tell you what it is, but it's certainly north of 70 or 80 to predict, because what you've got for that individual with these other models based on very large populations, you also know their creatinine clearance, you know their age, you know their gender, etc. You know the other medications they're on, although those are not usually very important for tenofovir. So you have all those other covariates. So all that variation I was talking about goes like this. It gets very small. There's a paper this week in Clinical Pharmacology and Therapeutics in an HIV setting where they used pharmacogenomic testing. The addition of the pharmacogenomic test, they cut that variation in half. It was atazanavir, ritonavir, and something else. But so that's another piece of information that can make it more expensive. But to get these if we did these drug levels for you across the street, we would charge $100. So for $200 in the clinic visit. But now you know what their profile looks like until they have some major life event, like they lose a kidney or their liver dies, before they'll have much of a change in that concentration time profile. So then if they come up for a routine visit at 3 months, let's say you did a 1-month check on PrEP, you're seeing them at 3 months because you want to get their creatinine to be sure that tenovir's not killing their kidneys. And then you draw a blood level. That's another $100. But they're either at target or they're not. If they're not at target, you know because you have their profile. Is that because they're not taking it? Because their kinetics are funny? Or is it because they're not, or their kinetics are funny? You can tell with that information. And I think you can tell reasonably which of those it is so that your intervention in clinic can be targeted. Now, I don't know how good adherence interventions are. The problem is that you have to have a good way to measure adherence to be able to test the quality of intervention.
I was thinking about research, not clinical.
So in research, I think, that's easy in a research setting. The issues again are the same though, that they have to do with cost and applying this. And we have, what's remarkable in these studies, so all the studies that I showed you, they didn't have it at the beginning, but by the end, all those studies had added some periodic pharmacologic assessment. And again, only one of those studies, only the CDC study, started with pharmacology, and Voice did as well. All the others did not start with pharmacologic assessment. They were added in later. In fact, in Partners, it was only added in because the adherence folks, David Bangsberger, wanted to look at adherence and added it in as a measure. And the plan there was to triangulate, I don't remember what the word was that you used, Amy, in terms of having, they have MEMS data, and which we're just starting to look at the data. The MEMS data, the drug concentration data, the pill count, to triangulate or pentangulate, because we have a lot of different measures, what the adherence is, to see how these measures agree, and what the determinants are, what the profile is for someone who does or doesn't adhere, at least in the PrEP setting.
Well, I'd like to thank everyone for coming and thank our speakers.